eliminate the microbes and dead tissues, and it is prolonged, sometimes it can be inappropriate. When it is directed against self-antigens, like in autoimmune disease, or against usually harmless environmental antigens. So it can be acute or chronic. Acute is in a sense that is rapid in onset, it has short duration and lasts for a few minutes to as long as few days. So there will be ultimately a fluid and plasma protein exudation, and it has predominant neutrophilic leukocyte accumulation. While the chronic inflammation can be more insidious in onset, it's usually longer duration, like takes days to years, and it is characterized by influx of your lymphocytes and macrophages. As well as there will be this vascular proliferation and fibrosis resulting in scarring. So this is the diagram that compares acute versus the chronic inflammation. So what can be the components of inflammations? It's a vascular in origin, vascular reaction, and there is cells involved there. And both these blood vessels and cells are activated by the mediators that are derived from the plasma proteins and various cells. Basically, these inflammatory cells, along with the blood vessels plasma proteins, they will continue this inflammatory process. Okay, this diagram, what we can see is there's this blood vessels, and there are these inflammatory cells like the polymorphonucleus leukocytes, there are plasma proteins, and lymphocytes and monocytes, you see, and as well as platelets, which are the components required for these inflammations. So what happens, there will be this one, they are activated, they are designed to kill these macrophages, so microbes and the dead tissues with the help of these monocytes and lymphocytes. So ultimate end product will be this elimination of microbes and dead tissues, and there sometimes this plasma proteins will come there as a form of complement, and there will be this ongoing initiation, propagation of inflammations with the help of these blood vessels like this nitric oxide cytokines, others that will help in diabetes of these cells there. And when there is chronic in nature, there will be ultimately proliferation of these blood vessels, and fibroblasts will come and there will be repairing. So steps in inflammatory response, 5R. First and foremost, there should be recognition of the injurious agent. There will be this recruitment of the leukocytes. WBC will come there where there is injury, and this WBC will try to remove this agent, and this inflammation will be regulated. Is depending upon this, how is this response? It can either go to resolution and repair. So those are the steps of inflammatory response. That's what we expect to happen. And externally, it will manifest as the cardinal signs. You already read about that one, the calor, rubor, dolor, tumor, and functional lassa, that is heat, redness, swelling, pain, and loss of function. It should be usually controlled and self-limited, the inflammations. You see, these mediators and cells are activated for a short time only, and they become degraded or become inactive as the injurious agent is eliminated. So various anti-inflammatory mechanisms become active for this to happen. So two major components of inflammation, the vascular changes will be in form of vasodilatation, increased vascular permeability, increased adhesion of these leukocytes, and migration of these WBCs through vessel walls. The cellular events that takes place is immigration of these WBCs. They will take help of other cells, that is cellular recruitment, and they'll be activated, that is WBC will come into action. So normally, this is how it looks like. This arterial tissue is there, that is, and this tissue macrophages and all that, and this veins, right? So when there is inflamed, there will be increased blood flow. You can see this arterial dilatation. There is increased this cellular migrations. Blood cells, WBC, can migrate from the blood vessels wall into the tissues. There is this capillary bed will be expanded, venule will also be dilated, and there will be leakage of these plasma proteins resulting into this edema, neutrophil will immigrate into this tissue. Ultimately, all these functions like rubor, dolor, color, and functional lascia, everything will be there because of this blood vessels dilatation and leakage of these plasma proteins. So stimuli can, as we said earlier, can be because of infectious in origin like bacterial, viral, fungal, or parasitic. Can be trauma like blunt or penetrating injuries, sometimes tissue necrosis from any cause, or foreign bodies if there are some splinters, dirt, sutures, and crystal deposits into the tissues. And immune reactions, some also known as hypersensitivity reaction, can also be the stimuli for this acute inflammation. So how these microbes, necrotic cells, and foreign substances are recognized are because of this capability, inherent capabilities of these phagocytic cells from their dendritic cells. They have these receptors there. They are known as toll-like receptors. And also inflammasome. Those are the multiprotein cytoplasmic complex that recognize product of dead cells such as uric acid, extracellular ATPs, as well as crystals and some microbial products. So they will be recognized by this WBC to initiate this inflammation. Here we can see toll-like this proteins there, bacterial wall, the cell wall, and lipid. They will function like this one. Sometimes this fungal lipocytes and also now present is the stimuli. So there will be formation of this from the cells. There will be a lot of this. When they go into there, they will release the cytokines and tumor necrosis factors. Then that will lead to your acute inflammation. Same thing happens when these pathogenic bacteria extracellular are there. They will go into these cells, and from there, this genetic transformation in formation of these caspases and a lot of these inflammations will occur that will result in secreted interleukin 1 beta to initiate this acute inflammation. So vascular changes. So this is you see normal blood vessels. The hydrostatic pressure is there because of this plasma proteins there. Because of colloid or oncotic pressure, there's nothing. This is normal. But what happens? Transudate will start because of this leaky vascular endothelium. The fluid will leak outside along with this proteins and all that. So there will be this edema will be there. So exudate is high protein content and may contain some white and red cells. When this red cells and white cells starts to go outside, that forms this exudate. In transudate, it has low protein content and few cells. So the cellular events for leukocyte recruitment and activations are like, as you have already read this in pathology. Okay, I took everything this one from the pathology. It's given in your surgical textbooks. So you know this diagram. That's what happens there. How this WBC starts to adhere to this endothelium, and from there how this diabetes occurs, and how this WBC goes into tissue. That is this events that occurs in cellular migration. So basically, those processes are known as this margination and rolling, adhesion, transmigration, and chemotaxis. The acute one, they have this neutrophils predominance, and inflammatory infiltrate during the first 6 to 24 hours is this acute one, and later these neutrophils are replaced by monocytes that occurs in 24 to 48 hours. So leukocyte activation, as we said earlier, microbes with this cell walls and all that will activate these transcellular membrane proteins like toll-like receptors and all that. And there will be this phagocytic of the cells which will go inside, and there will be this microbicidal killing up by the help of these leukocytes. Basically, they want to kill these living microorganisms, the bacteria and all that. So you see microbes, they bind with these receptors in the cell walls, they try to engulf it, put it inside, and here they will start to produce this radical, free radicals like nitric oxide, reactive oxygen species, which the main purpose of that one is to break down these microbes. That is what happens in your uh, phagolysosomes. So WBC can eliminate these microbes and their cells by phagocytosis, followed by their destructions in phagolysosomes. And that is caused by this free radicals like reactive oxygen species and nitric oxide that come from your leukocytes and lysosomal enzymes. Now you see this is, as I said earlier, this mechanism is to protect us from these microorganisms and dead cells, like this physiological role. But this process is also capable of damaging the normal tissue. That is usually the pathologic consequences of inflammation. So you see there are some disorders like acute respiratory distress syndrome. This is mediated by these neutrophils. Acute transplant rejection occurs because of lymphocytes, antibodies, and complement. Asthma is because of this eosinophils, IgE antibodies. Glomerulonephritis, it is mediated by your antibodies and complement, neutrophils and monocytes. Septic shock by your cytokines, and in chronic conditions like rheumatoid arthritis, usually this lymphocytes and macrophages and antibodies. Asthma, chronic asthma by eosinophils. Atherosclerosis by macrophages and lymphocytes. Chronic transplant rejections, also lymphocyte and macrophages. And pulmonary fibrosis, again this macrophages. So that's the various disorder which results because of this inflammation. Now, this chart, this table, what it's trying to say is that what happens in disease states, like in acquired bone marrow suppressions, tumors, including this leukemias, radiation, and chemotherapy, there'll be defect in production of this leukocytes. So ultimately, what happens there is the leukocytes are defective, and inflammatory processes are also defective. In diabetes, malignancy, sepsis, and chronic dialysis, the defect will be in adhesion on chemotaxis of these WBCs. In anemia, sepsis, diabetes, and malnutrition, the WBC which are there are defective in phagocytosis and microbicidal activities. That's why when there is this predisposing condition like this one, the inflammatory reactions can be lessened. That may be they are less effective in killing these bacteria. Some genetic conditions are there like leukocyte. Hello? Yes?
9828.
Uh, Umar Shah, can you please concentrate? People, can you hear me? Hello? Are you
Yes,
there?
sir, we can hear you.
Okay. Some genetic conditions like leukocyte adhesion deficiency
Yes,
1.
sir.
Yeah. Here, problem will be defective leukocyte adhesion because of mutation in chain of cluster density 11 and cluster density 18 integrants. In leukocyte adhesion deficiency 2, there will be defective leukocyte adhesion because of mutations in all these fucosal transferase that is required for synthesis of various oligosaccharides. In chronic granulomatous disease, there is decreased oxidative burst. That means this reactive oxygen species and all that, the production will be decreased there. In X-linked disease, the phagocyte oxidase membrane component, that production will be defective. In autosomal recessive diseases, phagocyte oxidase cytoplasmic components will be defective. In myeloperoxide deficiency, there is decreased microbial killing because of defective this MPO and hydrogen peroxide system. In celiac gases syndrome, there's decreased leukocyte functions because of mutation affecting protein involving lysosomal membrane traffic. Now you say what this table is trying to say is there are some acquired and genetic conditions where these inflammations will be less efficient. So what happens is you are more susceptible to have this infections and all kind of these diseases, because when your inflammations is lessened, that's basically your immunity is not so good. That means there's chance that you be killed by this infection and all these processes there. So outcomes of acute inflammations is this post-formation, and if it is in chronic, it is fibrosis of loss of functions. So as I said earlier, all kind of injury like infarction, bacterial infections, toxins, and trauma leading to acute inflammations, there will be these tissue level changes. And the resolution will be clearing of this new injurious stimuli, and there will be clearance of mediators and replacement of injured cells, and normal function will be there. So, but if that is not possible, sometimes there will be formation will pause, because pause is nothing other than dead and necrotic tissue, WBCs, and all that. That is the formation of abscess. And when it heals, ultimately what healing will lead to fibrosis. There is fibrocyte proliferations, and this when this fibrosis is there, normal cells will be replaced by this fibrosis, and there will be loss of function. In chronic inflammation, uh,
हाँ तो वो टाइम पे लेके गए
yeah. So injury, like viral infections, chronic infections, persistent injury, and autoimmune disease, there will be chronic inflammations with the formation of this angiogenesis, mononuclear cell infiltrate, and fibrosis scar, and healing process will loss leading to fibrosis. So, outcome of inflammation is either healing or pus formation or fibrosis, that is loss of function. Okay, serous inflammation. So, serous inflammation, it has outpouring of water, relatively protein poor fluid that is derived either from the plasma or from secretion of mesothelial cells lining the peritoneal, pleural, or pericardial cavities. And skin blister resulting from a burn or viral infection, that is also kind of serous inflammation. And fluid in serous cavity is called an effusion. Like example is pleural effusion, pericardial effusion. That is because of this serous inflammations. Serous is because why? There is less protein is there. When there's more protein and the WBC, it becomes exudative. Okay, fibrinous inflammation. This is because of more severe injuries resulting in greater vascular permeability. This allows large molecules such as fibrinogens to pass through this endothelial barrier. So fibrinous exudate has characteristic inflammations, and it blinds the body cavities such as the meninges, pericardium, and pleura. And these exudates are usually degraded by fibrinolysis, and the accumulated debris may be removed by the macrophages, resulting in restoration of normal tissue structure. Resolution can still occur in fibrinous inflammation. So when there is this extensive fibrin-rich exudates, they may not be completely removed, and instead they are replaced by this ingrowth of fibroblasts and blood vessels, and it starts to that process is known as organization. This leads to scarring and may have significant clinical consequences. Example is pulmonary fibrosis. Pulmonary fibrosis, I think in COVID disease, the long-term COVID disease, there is some kind of pulmonary fibrosis is there that has hampered the overall performance. But the data is still coming up. Let's see how it's progressed. Another example that I want to give you all out of this fibrinous inflammation is in pulmonary tuberculosis. After the resolution of inflammation and everything, there is bronchiectasis is a condition where there's consistent production of this purulent exudates and all that. That is also possibility. Okay, here's the picture that's showing this fibrinous pericarditis, depositous fibrin on pericardium. This is the pericardium, heart is there. So this is how it looks like. Now, suppurative, purulent inflammation and abscess. So here, there will be large amounts of purulent exudates, pus that consists of neutrophils, necrotic tissue, edema fluid, and also this bacteria may be there. Example, staphylococci that can cause this suppuration. So abscess are focal collection of pus that may be caused by seeding of pyogenic organisms into the tissue or by secondary infection of the necrotic foci. That means when this pyogenic organisms like the bacteria, when they go inside the tissues, there will be formation of this inflammation resulting into this abscess. Or when there is a necrotic tissue, let's consider some kind of inflammation, infarction has occurred, and if that turns into a necrosis, isn't it? So if it is secondarily infected by this bacteria, then there might be this pus formation. The example is, let's take a surgical wound. When there is surgery, it's inherent to bleed there. Okay. Now, after the surgery is finished, you close it. You do it properly. Now, consider there is no bacteria there. Okay. Now, what happens if there is this hematoma formation post-surgery in the surgical site? Sometimes possibility is there that secondary bacterial infection can occur, like you are going to puncture it somehow, or there is a small opening in the incision site. From there, bacteria can go inside this hematoma, and that can give rise to your secondary infection of this initially this sterile environment that will result into this suppurative inflammation and abscess formation. That's why hematoma is not good, or post-operative hematoma is not good. That's why they put this drain so that anything collection there can be drained. Of attempted repair, and it may become completely wall off and eventually